Bashir, Zikria is going to talk to us about cartilage regen after high tibial osteotomy.
All right, sorry about that. So I'm going to talk a little bit about cartilage regeneration after high tibial osteotomies and what happens after high tibial osteotomy and when you should do a high tibial osteotomy and when cartilage regeneration. I have nothing to disclose. This is actually a famous painting and a portrait of William Hunter. He's the one that first that recognized and said ulcerated cartilage is a troublesome thing. Once it is destroyed, it's not repaired. So we know that cartilage does not heal itself. We also know that cartilage is common. After an ACL injury, 50% of ACL injuries have cartilage injuries. 10%, you can see at the time of arthroscopy, this was Curl's study, she showed 10% had full thickness defects. This study out of Russia, they showed 97% of MRIs. They did MRIs on all these soccer players. They saw in high athletes, they saw 97% of them had asymptomatic cartilage lesions. Grade 1 and 2 were the most common. But we do know if you do get a cartilage lesion, you have a 3-fold time risk of getting a knee replacement in the future and risk of 5 times as an adult. So the overall prevalence in athletes is almost to 1/3, and these full thickness defects are even increasing. So the biggest thing is the majority of these lesions are increasing and they're complex. A cartilage lesion is complex. It's just not a focal cartilage defect that we just talked about before. And we know what it's going on in the US is more cartilage restoration procedures are becoming. But the most important thing that we have to understand is they're complex lesions. In the US, we have significant amount of total knee replacements. If you look at where we are in cartilage surgery compared to total knee replacements, where restoration is actually just beginning. But we do know cartilage procedures are increasing and cartilage restoration procedures are increasing. Microfracture and any type of bone marrow stimulation is trending downward. And I think that's the way it's been going for the last 5-10 years. But how do we know? So where does the osteotomy come in? We learn from our cartilage repair what fails, right? The most common mode of failure is malalignment. And other areas of failure, graft failure, meniscal deficient stability. But up to 56% of cartilage restoration failures are attributed to malalignment. And as Thomas Edison says, I have not failed, I found 100,000 ways it does not work. So we know if we do a cartilage procedure without an osteotomy, it's going to fail. The other thing we know is, this is the US data, we're in the US, well, as I showed you previously, we publish the most papers on osteotomies, but we do it the least. So we know how to talk about it, but we don't know how to do it. So you can see how it's getting, and we have to learn, and it's actually become very popular in the United States recently. So this is every articular cartilage algorithm is going to be similar to this. You got to take care of the comorbidities. We talked this morning about ligaments, instability. We talked this morning about meniscus. Now we're on to malalignment. But malalignment is the most common reason for failure. And if you look, everything below here doesn't matter unless you take care of the above, right? The cause and the symptoms of what happens. And I think that's where the art comes in. So there was a big thing in the ICRS about talking about what's a cartilage surgeon. Because anybody can do a MACI procedure, put a patch on a defect, but who can actually do the other procedures, like the meniscal transplant and also the osteotomies? And this is what I was showing you before. You can see in the US, we have the most publications, but if you look how many osteotomies we do, very rare. And we had a high failure rate originally with the MACIs is because the people weren't doing osteotomies. And we see most of our failures are because we don't do the restoration procedure with the concomitant procedure. If you look at the German registry, they do 46% osteotomy with their restoration procedure compared to us in the US. So what happens before? Why do you have this issue before? So when you have malalignment, you have an inflammation, the load increases inflammation, and it increases inflammatory. You get IL, interleukins, these cytokines, you get metalloproteinases, and these aggregases that actually eat up the joint. You lose the joint space, and then you get impaired defunction. As you can see here, the load can cause this biomechanical pathway, ultimately leading to osteoarthritis. And you can see here, this is where the overloading can cause this inflammatory cascade that breaks down the knee. And this is also happens anytime you get an inflammatory cascade in the knee, it'll break down the knee. Christian Latterman does a very good studies on ACLs with these inflammatory cascades and how it breaks down the knee as well when he followed them with biomarkers. What happens, what can the HTO do? Alter the load distribution, can reduce stress on the cartilage and cartilage remodeling. But one of the questions we have is, where do we do the osteotomy? Do we do it at neutral? Do we do it at, and I'll get to that. And we know this is bold study, shows significant 89% survival with your ACI after if you don't do it without the osteotomy as well. So my question was, where do you do it? Do we do it down the center? Or do we do it at Fujisawa's point, 62%? Or a noise point, when he says on downsloping of the tibial eminence? Do we overcorrect? Or do we go more 50, 55% slightly during the cartilage procedures? So what happens post tibial osteotomy? The biomechanical offloading, and you get subchondral stimulation. So this is important. You don't have it's just not cartilage, it's also the osteochondral unit. Once you take the load off, they can communicate better, and you change the environment. You know, the synovial milieu can actually destroy the knee, as I was saying, as the inflammatory process goes down. You can increase cellular activity, and you get reduced inflammatory response. You continue, the chondrocytes become more active as the inflammation decreases, and then your clinical outcomes improve. So, 2 studies, one in JBJS, one in arthroscopy, showed that if you do the high tibial osteotomy, you get cartilage regeneration was more seen. And these were the ones that were overcorrected without another cartilage procedure to Fujisawa's point, 62%, 60% or over. And what happens, the environment changes, right? You decrease the inflammatory response, the cartilage, and it feels that it's in a more secure environment. The other ones are with cartilage procedures. And there's several studies, 2 minutes, 1 minute I'll be done. To several studies, but most studies say if you bring the alignment should be around 50, 55%, and you do your cartilage procedure with that. The theory is that the cartilage procedure will fill the defect, and it will give you the space, and the alignment will be maintained almost like by the osteotomy. And then finally, the Koreans have been doing a lot of this Cartistem, and they've been doing it. It's very similar to the picture I showed you of the pretty drilling. They do the pretty drilling with an osteotomy, and they've shown very good results with mesenchymal stem cells. And the theory there is, as the good doctor mentioned before, the mesenchymal stem cells don't differentiate. They do a paracrine type effect. And this has become very popular. If you go in the Middle East, there's a Korean hospital everywhere now promoting this Cartistem type technique. My take-home message is it's becoming a younger and active population. The cartilage restoration is increasing. The trend of procedures are becoming more cellular. But with the cellular, the cost goes up, so you have to take care of the comorbidities, specifically malalignment, ligament instability, and meniscus deficiency. The HTO is a biomechanical unloading, which can decrease inflammatory response and actually make the subchondral bone healthy again. HTO alone or HTO with the cartilage procedure, overcorrection for the HTO alone, and neutral to slight overcorrect for the HTO cartilage. And I think that definitely, as we talked at the first talk, there's a lot of good literature now coming around, not good literature, but there's a lot of studies coming on MSCs with an osteotomy. These are some of the cases, but I'll just skip through them. And then we have a conference, Regenerative Medicine in Miami, and then we also have a conference, ICRS in Aspetar. Thank you.